Thank you for joining Cancer Support Community Atlanta for the Tell Me More series. This program focuses on pharmacogenomics versus genetics and is facilitated by Porscha Johnson with Northside Hospital Cancer Institute. For more information on other installments of the Tell Me More series, please visit Cancer Support Community Atlanta's website, cscatlanta.org.
Hello, everyone. My name is Dr. Porscha Johnson, and I am the Medical Oncology Clinical Pharmacy Specialist here at Northside Hospital Cancer Institute, as well as the lead clinical oncology pharmacist for our Genomic Oncology Advisory Board. The goal of this pharmacogenomics versus genetics feature of the Tell Me More series is to serve as a readily available resource to someone who may be newly diagnosed or just beginning to navigate the various treatment options throughout their cancer care continuum. It is my hope to empower patients and their designated loved ones to be key players in the shared decision-making process during treatment planning. Here, I have listed key terminology that may be frequently referenced in your discussions about pharmacogenomics and genetics. Please feel free to refer back to this slide throughout your learning journey. Upon completion of this video, you will be equipped to understand the following: understand the role of genetics in cancer, explore the significance of genomics in cancer treatment, and review real-world applications of genomics and genetics in cancer care. Now let's recall the foundational principle of precision medicine. As you can see from this illustration on the left, although these gentlemen both have the same diagnosis and are both receiving the traditional standard of care, they simply do not respond the same. Now, from the illustration on the right, you can see that although it is the same diagnosis, each patient must be treated individually based on their personal genome and biomarkers, eliminating the one-size-fits-all method and thereby optimizing drug therapy through a personalized approach. Remember, pharmacogenomics was founded upon the idea that individuals' genetic makeup and tumor biomarkers are associated with their prognosis and tumor response to therapy. Please feel free to refer to my Pharmacogenomics Tell Me More series video for further explanation of this concept. As you can see from this depiction, molecular profiling is a must in order to determine the clinical implications of an individual's prognostic markers as well as predictive markers of drug sensitivity, resistance, and possible adverse effects. These biomarkers are then utilized to prescribe the right drug for the right patient on the first try. Select pretreatment genetic enzyme status is important for treatment planning and calculating safe drug dosages for therapy. For patients with reduced enzyme activity, certain drugs may be given at a significantly lower dose, or alternative medications can be used to reduce the risk of associated toxicities. A few examples include DPYD for 5-FU or fluorouracil and capecitabine or Xeloda, TPMT or NUD-T15 for azathioprine or mercaptopurine, G6PD for glucarbidase or methylene blue, or even UGT1A1 for irinotecan or Trodelvy. Again, the implementation of precision medicine requires buy-in from involved stakeholders to evolve best practices and standard of care. This is a news clipping from an unfortunate patient case heard around the world. Because of a genetic condition that affects as many as 8% of people, his body could not process the chemotherapy drug, and this gentleman unfortunately passed away due to preventable adverse effects from receiving capecitabine for his bile duct cancer. It was later determined that he was DPYD deficient, which is a testable genetic trait. These are just a few examples, but as you can see here in the following drug package inserts, the FDA clearly outlines such warnings about certain enzyme deficiencies and how they can be harmful to a patient. This medication package insert is for fluorouracil, and the second one is for capecitabine or Xeloda. There are even guidelines developed by CPGx, or Clinical Pharmacogenetic Implementation Consortium, to better guide clinicians on how to dose adjust for their patients with DPY deficiency. Therefore, providers should most definitely recommend preemptive testing for all patients with a drug package insert outline warning for potentially fatal genetic polymorphisms or deficiencies. Germline mutations are inherited genetic variations from the sperm and egg of the individual's parents, such as BRCA1 or BRCA2. Germline mutations are something that you are born with and will never change throughout your lifetime. Somatic mutations are acquired genetic variations, which typically derive from the tumor or blood or bone marrow and hematologic malignancies, as well as environmental factors. Now let's review some synonyms for genetics that may be interchangeably referenced throughout your conversations with your provider, such as your oncologists, nurses, care coordinators, or pharmacists. We have biomarker testing, PGx, precision oncology, hereditary testing, germline testing, and precision medicine. Our genes play a crucial role in determining our risk of developing cancer. Genes are segments of DNA that provide instructions for the growth, development, and functioning of our bodies. Certain genes regulate cell division or repair DNA damage, and alterations in these genes can increase the risk of cancer. Certain genetic variations can increase the likelihood of developing cancer, while other genetic factors may provide protection. Inherited gene mutations can predispose individuals to certain types of cancer, such as BRCA1 or BRCA2 mutations linked to breast and ovarian cancer. Conversely, some genetic variations may confer protection against cancer development, reducing the risk. By studying genetics, doctors can identify individuals who may have an increased risk of certain types of cancer and provide personalized care and screening recommendations. Genetic testing can identify known cancer-associated gene mutations, allowing individuals with higher risk to take preventive measures or undergo more frequent screenings. Here I have listed the 3 different methods for genetic or germline testing. To the far left, we have a buccal or a cheek swab. To the middle, we have saliva testing, and then the far right is a blood draw. So here's our take-home message, right? With a simple cheek swab, saliva test, or blood draw, we can identify variants to save millions of lives, billions of dollars, and uncountable hours wasted on inadequate therapy. By gene testing yourself and your family, you are breaking through and taking control of your medication health. Genomics allows scientists to analyze the genetic makeup of cancer cells and understand the specific changes that contribute to the development and progression of cancer. Cancer cells often acquire genetic alterations such as mutations or changes in gene expression that drive their abnormal growth and survival. Genomic analysis helps identify these alterations and provides insights into the underlying mechanisms of cancer. By studying the genomic profile of a patient's tumor, doctors can identify specific genetic alterations that drive the cancer's growth and tailor treatment plans accordingly. This approach, called precision medicine or personalized medicine, aims to match targeted therapies to the specific genetic vulnerabilities of the tumor. For example, if a tumor has a specific mutation that promotes its growth, a targeted therapy can be selected to inhibit that particular mutation and slow down the cancer progression. Genomic information can help guide the selection of targeted therapies that are designed to specifically target the genetic vulnerabilities of the tumor, potentially leading to more effective and personalized cancer treatments. Targeted therapies can be more precise and less harmful to healthy cells compared to traditional chemotherapy, which affects both cancerous and healthy cells. Here I have a chart that outlines the variant classifications for pathogenicity. Pathogenic would be considered directly contributing to the development of the disease. Additional evidence is not expected to alter the classification of this variant. If the variant is likely pathogenic, it is very likely to contribute to the development of disease, but scientific evidence is currently insufficient to prove this conclusively. An uncertain significance or a variant of unknown significance, or VUS, means that there is currently not enough information to support a more definitive classification of this variant. Likely benign means that it is not expected to have a major effect on the disease, but the scientific evidence is currently insufficient to prove this conclusively. And then a benign variant means that this does not cause disease at all. Additional evidence is not expected to alter the classification of this variant. Classification of these variants can lead to clinical trial eligibility for established clinically actionable mutations, or even studies researching VUSs, or variant of unknown significance, which could eventually lead to predictive or prognostic factors in the future. If a VUS is reclassified as pathogenic or likely pathogenic, the ordering provider is responsible for notifying the patient and referring to a genetic counselor. Genomics and genetics has revolutionized cancer care by enabling precision medicine approaches. Precision medicine considers the unique genetic makeup of each individual and their tumor to guide treatment decisions. It allows for more targeted and effective therapies, improved patient outcomes, and reduced side effects. Genetic testing can identify inherited gene mutations that increase the risk of certain types of cancer, allowing for proactive measures such as increased surveillance or preventive surgeries. Individuals with known inherited gene mutations can take preventative actions such as increased screening or risk-reducing surgeries like mastectomy or oophorectomy. Identifying these mutations in family members can also help guide their cancer risk management strategies as well. Genomic profiling of tumors can help identify potentially therapeutic targets and guide the treatment selection of targeted therapies, leading to more precise and effective cancer treatments. Genomic profiling helps identify specific genetic alterations or biomarkers in tumors that can be targeted with therapies designed to inhibit these alterations. By performing tumor normal match analysis, providers can subtract the normal tissue and deduce the source of cancer by process of elimination. As you can see here, the picture to the left, the somatic variants are detected by comparison with the normal sample. So we have a non-contaminated normal sample in the pink, and then a matched tumor, and you can see we only have one normal cell, but we can subtract and figure out what exactly is the tumor. In the picture to the right, the somatic variants are rejected due to mutation or mutated reads in the normal sample. So we have a contaminated normal with two different gray tumor cells right here. And then when we move over to the right, we can see exactly what we're looking at as far as subtracting the tumor from the normal cells. This is not an all-inclusive list, and providers are given the autonomy to select the commercial vendor of their choosing. However, these labs listed here are some of the more common commercial vendors you may encounter. Remember, vendors play an extremely important role in the precision medicine space as they are able to provide clinicians with high quality and certified data, manage, or even prevent your cancer. These assays vary in size of panels and they have limits of detection. Recreational or direct-to-consumer genetic testing platforms such as 23andMe and Ancestry.com can provide useful information to determine one's origin and to be connected to long-lost relatives. However, these recreational tests do not detect cancer screening genes and should not act as a substitute for clinical judgment when cancer treatment planning. In addition, upon completion of these tests like these, you now give that company permission to your data, so it is very important to clearly understand all of the terms and conditions beforehand. 10% of cancer is hereditary. It is vital to understand the importance of genetic screening for cancer patients, survivors, and their families. All cancer is genetic, but not all cancer is hereditary. The NCCN, or National Comprehensive Cancer Network, has detailed hereditary cancer screening guidelines. Now, what are the possible results of testing for hereditary cancer? About 50% of patients will have a negative result, meaning benign. About 40% of patients will have an inconclusive result, meaning a VUS, or variant of unknown significance. And about 10% of patients will test positive for a pathogenic variant, which is a bad copy. A negative genetic test does not mean you will never get a certain type of cancer, but you must also take into account possible environmental factors such as asbestos, Agent Orange, things of that sort, as well as epigenetic factors. As you can see here, a person is born with 23 chromosomes. These arrows depict the different mutations that are associated with each chromosome and the propensity to develop a certain cancer. Higher likelihood of colon or uterine cancer if Lynch syndrome is suspected, or breast cancer, such as BRCA1, BRCA2, are all seen within certain mutations in various chromosomes. Genetic testing may provide options for surgery, treatment, and cancer screening, such as increased screening for colonoscopy every 1 to 2 years, MRI of breast, medicines to reduce cancer, preventative surgery, such as removal of uterus, ovaries, colon, or breast. The need to incorporate risk-reducing lifestyles such as weight control through exercise and healthy diet, smoking cessation, decreasing alcohol intake, and to consider family testing. When genetic testing, there are a couple of ethical considerations to consider. There are barriers to genetic testing such as historical incidents such as Henrietta Lacks and the HeLa cells, which have resulted in some mistrust or apprehension towards the medical community. Ethical dilemmas surrounding genetic screening and testing also include barriers to testing such as literacy, education, income, culture, religion, and social and family relationships, and then also the need for a comprehensive, informed consent. There's also the role of deciding whether or not to disclose your test results to at-risk family members. Patients may exercise his or her autonomy and decide not to disclose their test results to adult family members at risk. We should also be wary of genetic testing in pediatric population and making sure that for those that are underage that we have parental consent and knowing what the repercussions of that may be of the results. Access to genetic screening, insurance may be an issue, or even when the results are disclosed to at-risk relatives, decisions about prophylactic therapy needed to be made, such as a surgery, double mastectomy, things of that sort, may be refused. Also, the strained resource of genetic counseling due to staffing shortages. The updating a patient on variant reclassification is also an ethical consideration. We do have a duty to warn. If there is a variant of unknown significance that is reclassified as pathogenic or likely pathogenic, the ordering provider is responsible for notifying the patient and referring to a genetic counselor. There are also some legal considerations. Again, making sure that the patient has an informed consent, notifying them of the duty to warn or disclose to relatives or family members, and then also the Genetic Information Non-Discrimination Act, known as GINA, which we'll go over in the next slide. GINA, or the Genetic Information Non-Discrimination Act, prohibits medical insurance or employers from discriminating against individuals based on genetic information. However, it does not protect against the use of life insurance or long-term disability, and does not protect those covered by IHS, VA, federal employees, or U.S. military plans. The question is always asked, who owns the genetic test results? Of note, the lab cannot use your identifiable data for any research or purpose without your consent. Let's review some economical or financial considerations for genetic testing. We're looking at insurance coverage, also financial toxicity, whether the patient is insured, underinsured, or uninsured, looking at financial assistance such as grant or foundational funding, and then knowing that patients with Medicaid are less frequently receiving next-generation sequencing testing compared with patients with other health insurance. Payers determine whether a patient has health insurance coverage also to participate in clinical trials. The difference in coverage, along with other requirements of clinical trials, can contribute to financial burden or barriers to enrollment. I've included here an example of medical insurance coverage for pharmacogenetic panel testing. Please note that every insurance company has different stipulations and coverage policies, so please be sure to check with your current insurer, as prior authorizations are sometimes required for testing. For those who may be uninsured or underinsured, please be sure to clearly communicate your patient needs throughout your cancer care continuum, so the financial assistance or grant or foundational funding can likely cover any expenses. Here's also an insurance plan from Humana as well. Now let's look over the social considerations of genetic testing. So recreational genetic testing, such as the 23andMe or Ancestry.com, we know that those direct-to-consumer testing focus on genealogy and are not intended to guide medical decisions. They do not have comprehensive assessment of DNA damage repair genes such as BRCA1 or BRCA2, and they lack clinical grade precision. Social determinants of health, such as redlining, food deserts, caretaker responsibilities, childcare, insurance coverage, transportation, things of that sort, are also social considerations for genetic testing and the repercussions that come with it. Inconsistency in racial, ethnicity, and ancestral categorization has also been an issue. As you can see from the picture to the right, these are very basic questions of, are you Hispanic or Latino? Yes or no. And then what is your race, based on these 5 different categorizations. It's important to note that race does not equal ethnicity, which also does not equal ancestry. Genetic studies are disproportionately conducted in white male European populations, and this leads to a lack of access to tumor sequencing and limited ability to enroll in clinical trials and lack of representation in our clinical trials. Inconsistent use of racial categories in clinical trial and research studies leads to such a disparity. The NIH's All of Us research program has vowed to correct this issue. In addition to pharmacogenomics, germline genetic risk assessment is becoming an integral component of cancer care. We must recognize the importance of clinical judgment and patient individualization in treatment planning, dosage modifications, and toxicity prevention. We must have a consent to biomarker testing for both somatic and germline, and that requires an in-depth counseling for well-informed decision-making by patients. Lastly, the implementation of precision medicine requires buy-in from involved stakeholders to evolve best practices and standard of care. Northside Hospital Cancer Institute's Cancer Research Program is one of the largest community-based oncology hematology programs in the nation, and is one of the few cancer research programs in the country offering phase 1 through 4 clinical trials. One of the strengths of Northside Hospital is that we have the clinical trials in the community. This provides our patients access to newest treatments close to home. The decision to seek identification of these biomarkers and act upon them has the potential to dramatically alter a patient's equitable access to groundbreaking, revolutionary clinical trials and overall treatment outcomes. Please see the contact information below. Here I have listed helpful resources to help guide your conversations with your loved ones and providers. The All of Us Research Program, the National Human Genome Research Institution, UT Southwestern Medical Center, and the American Cancer Society. This now concludes today's presentation. However, for more information, please feel free to access the following resources, where you'll learn more about my love for all things genomics and how the clinical utility of pharmacogenomics and genetics can truly impact a patient's most optimal outcomes. I will end here with my contact information. I truly hope that I have been able to highlight the unique value pharmacogenomics and genetic provides to cancer care. I would like to thank the Cancer Support Community of Atlanta in affiliation with the Northside Hospital Cancer Institute for the opportunity to speak to you all. Thank you.
Thank you for watching this installment of the Tell Me More series. We invite you to visit cscatlanta.org to learn more about the virtual and in-person oncology programs available through Cancer Support Community Atlanta.